Okay, so we'll begin. Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you can visit our Blum Center website at massgeneral.org/Blum-Center. Please note that everyone has been muted. Everyone is in listen-only mode so that we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. Paul, would you like to pull up your slides?
Sure.
So while Paul pulls up his slides, I'd like to welcome you all to Paul Arnstein. Paul is a clinical nurse specialist for pain relief at Mass General Hospital. He works with patients and health professionals to provide high-quality, safe pain control. With over 40 years of experience in the pain field, he has helped patients in pain with different pain types across the lifespan. In recognition of Pain Awareness Month, he joins us today to give a talk on pain management. So please join me in welcoming Paul.
Thank you very much, Amy, and welcome to all who have joined. This is the 20th anniversary of Pain Awareness Month. It's also the 25th anniversary of National Recovery Month. And I'm going to be talking about pain and its treatment, finding the right balance. And in particular, some of the questions that have come up in recent years about pain do relate to opioid use disorder or other substance use disorders. So I'll be touching upon some of those matters as it does relate to pain as well. And so this pain is a universal experience. It's biopsychosocial, meaning it affects the body, the mind, the spirit, social interactions, and it's contextual. So meaning of the pain has an important role in how it's perceived. That this is something that it's a powerful stressor, so it does trigger the fight, flight, or freeze response, and it's a teleological adaptive response, which means that things are the way that they are because that's how it works best for survival of the individual, survival of the species. So if we didn't have pain, that caveman wouldn't know to be afraid of the saber-toothed tiger, to fight or flight in order to survive as an individual and as a species. And that's what makes it particularly difficult to treat pain, because it is so important for our survival and survival of the species that we can't completely eliminate it from our lives. Now, there are rare individuals who are born unable to experience pain, and generally they don't survive their teen years because it is that important for survival. I'm trying to figure out, probably for as long as people have been around, what is this thing of pain and how do we best understand it? And really, revolutionary change in our understanding of pain came about during World War II, where scientists and field surgeons and others asked the question, how is it possible that a shot could hurt worse than being shot? And the reason for this experience was prior conflicts didn't have penicillin. But what they were experiencing at the battlefield was that soldiers would be coming in with limbs blown off or huge gaping holes in their abdomen, saying they weren't hurting at all. But then when you give them a shot of penicillin, you would get what's called the chandelier response. And you have to peel people off the chandelier. So it really didn't make sense where, a shot hurt worse than actually being shot, when there seemed to be so much less tissue damage that was involved with that. And right here in Boston, Melzack and Wall published a paper in 1965 and on the gate control theory of pain. And that changed a lot of the things that really explained how a shot could hurt worse than being shot, as well as some of the other experiences that we have with it. So that with this theory that when you have tissue damage, that it opens the gate, or you have a positive influence on the pain transmission centers in the spine. But then there's the influence of large inhibitory fibers that could close the gate. And that was things like in the field example that I gave, the warmth of blood, the pressure of a dressing, some of those types of things that would, the coolness of breeze. So cool, warm, pressure are things that could diminish the ability of pain signals for getting through. Also, there were thoughts, feelings, and motivations. Now, in some senses, that these thoughts, feelings, and motivations might help the signals of pain get through. And in other instances, they might prevent the pain signals from getting through. So for example, if the person's thoughts, feelings, or motivations were, wow, I'm alive, I get to leave this high stress environment of the battlefield, that would diminish pain awareness in that setting, as opposed to people who would be thinking or be of the mindset, oh my God, I'm gonna die, this is awful, this is terrible, that might be something that would make it easier for the pain signals to get through, with the net result being to think, feel, and respond to pain. I did have the opportunity to talk with both Melzack and Wall, who wrote this theory that really led to a lot of innovations and research in the latter half of the 20th century and so far in the 21st century, about what their thoughts were. And Patrick Wall, who was one of these field surgeons that came up with the question, and he was a neuroscientist, had said, if I had to rename the theory today, I'd call it the gain control theory, because gate control theory, we were thinking there was an on-off switch to pain. And we now know that there's no on-off switch to pain. That instead, the gain control model of pain is something where it's more like a volume dial or a dimmer switch. There are certain things that are amplifiers that can turn the pain signal or the volume up. And this gets in the way of activity, healing, and quality of life. Or there are dampeners that are able to turn the pain signals down, facilitating your ability to function, heal, and have a high quality of life. And these volume dials, if you will, or dimmer switches do occur at the tissue level, at the spinal level, at the mind level, the spiritual and the social levels. So pain is more than just the tissue damage. And John Lozier out in Washington had put together this model here, that we have this nociception, which is the actual tissue damage that triggers some signals into the nerves. And as the nerves get active and fire along the pain pathways in the spine and in the brain, that's what pain is when you perceive it. But then there's also these amplifiers and dampeners that modify its intensity. And then when you put it into perspective, your thoughts, feelings, the context, what does this pain mean? Is it something I need to pay attention to, or are there dire consequences to this pain? That leads to some of the suffering and some of the pain behavior that we see. So sometimes people might have the same exact illness or surgery or injury, and they're not showing any signs of pain. And other times there's a tremendous amount of distress and suffering in our behavioral observation of what's going on. But it does come down to some genetic and physical factors, as well as how the nervous system is primed and set up, and thoughts, feeling, context, our values, expectations, and other things. But pain not only affects the individual, it also affects loved ones, it affects the person economically, it affects our healthcare systems and society overall. And when we look at the prevalence of pain, did I miss a slide? No. This pain during the opioid crisis is something contextually that we have seen that some of the practices that led to some overprescribing of opioids some 10 or 20 years ago really did increase the use of opioid drugs. And we did see an overdose death upsurge by almost threefold of non-opioid drugs and almost fourfold from opioid drugs. So it's not just about opioid drugs causing these overdose crises that we have, but overdoses to opioids are a big part of the problem. And one of the thoughts behind this was that the prescriptions for opioids really peaked in 2012 because we really had limited understanding about pain. We wanted to simplify the treatment of pain. We know that pain was well treated by opioids in the setting of cancer when we didn't have very good treatments for cancer. And a lot of times when we were treating cancer, it was an end-of-life situation as opposed to nowadays where people are survivors of cancer for many months, years, even decades. But there were many other factors in terms of the pharmaceutical industries and payers and health administration. And with all of this flood of prescribed opioids that were available out there, it was estimated there was 10% leakage of prescribed opioids. So not necessarily what was getting to the patients, but when the manufacturers sent out their shipments, there was some theft that was going on there, some theft or miscounts that were happening at the pharmacy level, at the prescriber level, and at the patient level. And a lot of patients, once they no longer needed their opioids, just kept the opioids in their medicine cabinet where they might be taken by people who were not authorized for its use. Since 2016, we've seen the fastest drop in opioid prescribing. Latest estimates are about a 75% reduction in opioid prescribing since 2012. And we've seen historic highs in fatal overdoses related to opioids and other drugs. So one of the things that's happened as a result of our linking pain and the opioid crisis is that we've gotten so good at reducing opioid prescribing that we might have overshot the target in some extent to the point where people with pain and opioid use lack access to care. So if a person has had pain and they've been on opioids to treat that pain, there's a reluctance for prescribers to continue to prescribe, or they may lose access to the prescriber if they retire or change their practice styles. But also people with opioid use disorder, if they have pain, that they're less likely to be accepted into opioid treatment programs because they have pain as well. So we're in a state where we really have to fix access to treatment, both to pain and opioid use. And it's not just about pain. People with chronic pain and opioid use are increasingly lacking access to primary care for other health matters other than pain. When we look at the cost and prevalence of opioid use disorder, that this is a major public health problem with 20 million Americans meeting the diagnostic criteria for substance use disorder, also called addiction, 2 million with opioid use disorder, with rates increasing, over 100,000 global deaths last year were estimated by the World Health Organization. And last year in the United States, we saw historic highs from all drugs. And it might have been some of the effects of COVID, where there was more substance use going on, but 93,000 overdose deaths were estimated for last year. 70,000 of them were opioid overdose deaths. And that's a rise, a significant rise since the 2015 rates where we had significantly fewer. But estimates from the CDC suggest that 84% of these opioid overdose deaths are from illicit sources of opioids. And so the illicitly manufactured fentanyl is the primary one, with heroin also among these drugs that are counted into these figures. And the cost of opioid use disorder is estimated at $1 trillion a year in our country. And that counts healthcare, disability, criminal justice, and social services that are provided to those with opioid use disorder. Having a little trouble with advancing my slides, I might have skipped over the prevalence and costs of pain, but that has fivefold higher prevalence rates in terms of at least chronic pain, and low back pain has been a leading cost of healthcare globally for the last 30 years. when we look at Massachusetts rates in terms of opioid overdose deaths, Massachusetts is further ahead than many other states. As far as at 2014, they said we really want to get a handle on what people are dying of when we count them among that classification of dying of an opioid overdose. And so we see from these statistics that for 2020, so last year, 92% of the people who died of an opioid overdose had illicit fentanyl in their system. 46% had cocaine in their system, 14% heroin, 31% benzodiazepines like Valium or Ativan, 17% had prescription opioids in the system, whether it was prescribed for them or not, and 9% had amphetamines in their blood. And when you add these things up, on average, people had more than 2 of these drugs in their system at the time of their death. And so it's not something that is unique to prescription opioid or something that's inherently harmful about opioids when they're used as prescribed, but it's more about a combination of drugs, both prescribed drugs like benzodiazepines or amphetamines that might be taken at the same time as prescribed opioids, or it might be the concurrent use of some illicit substances along with prescription opioids. So when we look at the different types of pain that really guide some of our thinking about what's the best way to treat pain, one of the classifications when we think about how pain works is nociception. So I provided a very crude drawing about how the pain system works. And we think about this nociceptive system as being somatic or visceral. And so somatic is skin, muscle, bones, connective tissue. Heaven forbid I fall down a flight of stairs. When I get to the bottom of the stairs, I can close my eyes and I can point to different areas and say, I have a cut here, I have a bruise there, I have a broken bone there. It's a very specific system where the intensity matches the amount of tissue damage, and there's tenderness at the sites and so forth that happens. The tenderness might come a little bit later as inflammation sets in. And then there's visceral pain. And visceral pain comes from damage that occurs to our organ system. So it might be blood vessels, it might be our heart, our liver, our gallbladder. This type of pain tends to be a little less specific. So you really can't tell how bad the damage is to the organ from how much pain there is. In fact, many older adults have what are called silent heart attacks because they don't necessarily feel the pain, or they feel it in unusual ways. They might feel excessively tired, or they might be excessively sweating or short of breath, or they might have shoulder pain or jaw pain or left finger pain, or women might have pain under their breasts or between their shoulder blades. And so it's a less organized system that brings messages to the brain about damage that has occurred to our organ systems. And then there's neuropathic pain that occurs when the nerves themselves are damaged or they're not functioning properly. And this occurs to our peripheral nervous system, so out in the extremities or near the skin or muscle, that, for example, a person with a pinched nerve from a herniated disc, they might describe that pain as being, feels like you get an ice pick red hot and you stab it in there and you send a lightning bolt down to the foot. But those are some typical descriptions of peripheral neuropathies, whereas central neuropathies, when it involves the spinal cord or the brain, such as people who have had spinal cord injury, 50% of people, even though they can't feel or move below the level of where their spinal cord injury is, they have pain there. And also people who have certain types of strokes have unusual types of pain. And it might be what we call dysesthesias. So it might be this numbness or tingling or unusual sensations, but when it's there day in and day out, it really is perceived as being painful. We also have something called small fiber neuropathy that we can do some biopsies and identify people who have unusual patterns of pain, or as we're looking at these neuropathic types of pain that are more typically described as burning, shooting, stabbing, as I mentioned, or deep ache. that it might be related to small fiber neuropathy that is genetically modulated, so it does tend to run in families. Then there's also another class of pain that doesn't really fit these other molds, and they call it nosoplastic pain. So it seems like it's a neuropathic type of pain, but we can't find anything wrong with the way the nerves are functioning, or we can't find any lesions or other things on nerves to explain why the pain is present. This is believed to be secondary to peripheral or central sensitization. When we have pain in our nervous system, that it creates changes within that nervous system. And that's one of the reasons why when people have acute pain, or when we know people are going to have acute pain, such as a major surgical procedure, we're going to take steps to prevent that pain or stay on top of that pain and treat it so that the pain doesn't get wound up in the central nervous system and set up some of these self-perpetuating patterns where we're more sensitive to pain. The pain gets amplified and the pain spreads and sort of takes on a life of its own. There's also something called sympathetically influenced or maintained pain, and that's where people have pain that is responsive to stress responses. And when I talk about stress responses, it's not just emotional stress, but it's also physical stressors such as overexertion, or it might be thermal stressors. So some people have pain that gets triggered by very hot or very cold weather, or very changeable weather, so that when we're having thunderstorms or major storms coming through, their pain gets worse. And so those are some of the different mechanisms and some of the different ways that we categorize the different types of pain. But we also categorize types of pain in terms of how long it lasts. So acute pain, generally, it comes on suddenly. Oftentimes we know what the cause is. It's transient. So once healing occurs in a matter of days or weeks, the pain goes away. Oftentimes the intensity is aligned with the amount of tissue damage, and we know what's causing it, but it may recur. And so a form of recurrent acute pain might be a migraine headache. People might have several hours of a migraine headache that recurs once or twice a month. There is a chronic form of migraine that occurs for more than 4 hours per day that people experience it for more than 15 days a month. So that might fall into the chronic pain category there, but oftentimes headaches are categorized differently than pain in other locations in our body. With chronic pain, it may linger after acute pain. So there are different definitions, but depending on what we would expect for normal healing time based on the underlying cause. But generally that pain that lasts for more than 3 to 6 months in duration is considered to be chronic. Oftentimes the intensity is not aligned with the amount of tissue damage, or the tissue might have healed and yet the pain persists. And it may or may not subside over time. And then there's acute on chronic pain. And so people who have this chronic pain, they might have acute flare-ups of their pain, or they might have chronic pain. And oftentimes with chronic pain, there are some changes in the nervous system, in the amount of the receptors that we have for pain, in the how easy it is to transmit the pain through the spine and to the pain sensing systems of the brain. And so when people are exposed to acute pain, such as a broken bone or a surgery or an acute illness, that their pain is amplified, or it's much worse than for people who don't have existing chronic pain. In 2022, the diagnostic classification system is changing so that we can better understand chronic pain. This chronic pain is, I mentioned that I missed a slide. It's highly prevalent. There's estimated over 100 million Americans who live each day with chronic pain that's lasted for more than 3 to 6 months. Some of it is primary. So we think that the problem is primarily a pain problem. Might be widespread pain, such as those with fibromyalgia, might be related to an organ system like functional abdominal pain, musculoskeletal pain, headache, or complex regional pain syndromes, or it might be secondary to something else like cancer or post-surgical pain. chronic neuropathic pain, secondary headache, and the like there. And I think that having this classification system in place is going to help us to better understand not only the prevalence of these conditions, but also the best ways to treat them. In addition to chronic pain, we consider something called high impact chronic pain. So a lot of people do live with chronic pain. I mentioned one in 4 or 1 in 5, according to the latest statistics. But about 23 million Americans are living with what's called high impact chronic pain. And that chronic pain is so severe that it impairs their ability to work or to perform usual daily activities, such as caring for themselves, the things that you or I might take for granted on a day in and day out basis. So, you know, pain is not just something that can be ignored. We do know that it affects virtually every system in our body, and it can result in some undesired consequences, including the development of chronic pain from acute pain. And for those people who do have chronic pain, we do know that this is the most common reason for people seeking healthcare specialty consultations. I mentioned that headache is, low back pain for 30 years has been the leading cause of burden of disease in terms of what it's cost healthcare systems in over 300 countries around the world. When looking at over 385 different healthcare conditions. It's not necessarily fatal, but in terms of what it costs, in terms of healthcare costs and disability costs, it's the biggest burden to societies around the world, accounting for 100 million years lost to disability in the last year alone around the world. There's a 50% increase in all-cause mortality within 10 years for people that are living with chronic pain. Oftentimes this is from cardiovascular disease or cancer. It's unclear what the connection is. It might be related to the treatments, because we know that there are some connections there with some of the medicines that we use, but there's also some change in the structure and function in the central nervous system, in the spine and in the brain, as I mentioned. And people might be exposed to long-term to potentially dangerous drugs. We do know that opioids do have a fatality rate. It's relatively small in percentage, but when you consider the number of opioid prescriptions that are written, it is a substantial number, and a significant number of people, although in the minority, do go on to develop an opioid use disorder. What's lesser known is that for people who are taking NSAIDs, and this is like Advil, Aleve, and some of these other types of medications, there are 20 different NSAIDs, which stands for non-steroidal anti-inflammatory drug. So ibuprofen, naproxen, celecoxib, that 5% will have a major cardiovascular, gastrointestinal, or renal event with 1 year of continuous therapy with a 1% fatality rate. So generally speaking, when you look at the label for even the over-the-counter non-steroidal anti-inflammatory drugs, it will say that if you're using it for more than 2 weeks, do it under medical supervision, because we do see a bump in the rate of developing cardiovascular disease or some of these other problems as soon as 2 weeks of therapy. But generally, it's when people are getting 3 to 6 months out of day in and day out use of NSAIDs, where we're seeing some of these things emerging, and definitely by a year. The celecoxib, which is a COX-2 inhibitor type of these NSAIDs, generally are safer for the first year, but by 13 months, you see it catching up in terms of some of these long-term effects. We do see some of the antidepressants that are used for pain treatment linked to an increased rate of death. Gabapentin use has doubled since 2012, primarily not used in an FDA-approved fashion. And there has been some concern, not only for it not being as effective as we once thought that it was for pain, but also it not being immune to overdoses or abuse. And so we're treading carefully with how we're using that and the doses that we're using that, especially for people who have pre-existing kidney problems. Harm from invasive procedures are much less common, and non-invasive procedures, so some of the non-drug ways that we control pain, are really markedly less harmful than the harm that has been associated with the use of medications. But some of these invasive procedures, such as nerve blocks or epidural steroid injections, to mention a couple, do have some potential for side effects or complications like infection, bleeding, reactions to the local anesthetic, which can cause cardiovascular or neurologic complications. There are also drug disease interactions. So people who have kidney disease or liver disease, we have to go cautiously with certain medications. And I did mention some of the concerns around the non-steroidal anti-inflammatory drugs. And whenever patients have addiction disorders, a best practice is really to work with a specialist. There's a lot of treatments that we use that work both for substance use disorders, especially opioid use disorders, and for pain. And so we can effectively develop a treatment plan that will treat both the pain and the addiction problem at the same time. If the patient is opioid tolerant, that we tend to have a little different strategy for treating pain. And basically, if a person is taking at least 60 milligrams of oral morphine a day, which would be 90 milligrams of oxycodone, for example, per day for at least a week, that they're considered to be opioid tolerant. And people who are opioid tolerant do tend to be more sensitive to pain than others who are not opioid tolerant. And we want to be careful in terms of preventing people from going through withdrawal syndromes by slowly reducing the dose and not suddenly stopping taking the medication. For severe around-the-clock pain, that we might think about looking at scheduling the medication rather than taking it on an as-needed basis. And for people who have kidney or liver disease, fentanyl or methadone tend to be the better alternatives, although for other people, these are considered to be higher risk opioids. There has been a lot of talk in recent decades about the fact that exposure to opioids can actually increase pain, and there's some good science behind that, that we do know that even with one exposure to opioids, that it does activate the NMDA receptors that increases excitatory amino acids in the spine and in the brain. It activates glial cells that are part of our immune system that irritate nerves and that can actually amplify the signals of pain. And so that's why we tend to hold off on exposing patients to opioids unless they're needed, or we tend to keep the doses as low and the duration of therapy as short as possible when people do need opioids. Before we prescribe opioids, we look at their risk of abuse. So we might be asking questions about personal or family history of substance use disorder, whether it be alcohol and tobacco, prescription drugs, or illicit substances. Also looking at personal and family history of mental illness, adverse childhood events, including history of sexual abuse. And those people who are at highest risk of overdose when exposed to opioids are the very old, very young, morbidly obese, people with sleep apnea who've recently had abdominal or chest surgery. If they have concurrent sedative use, so things like Benadryl or Valium or Ativan, that they're 4 to 10 times more likely to overdose than people who don't have those other medications being used at the same time. People who have not been exposed to opioids over the past weeks or months, and those who have major organ dysfunction increase the risk of overdose. But when we think about who's at greatest risk of developing an addiction disorder, the highest risk is with non-medical use. And so we separate out prescribed use versus non-medical use. Non-medical use is a person who might have been in the hospital and been getting 2 oxycodone tablets, for example, every 4 hours for pain. And then they go home with a prescription for 1 pill every 6 hours. And they might decide, well, in the hospital, it was safe to have 2 pills, so I'm going to take 2 pills. So there's this unauthorized dose escalation. Or they were giving it every 4 hours while I was in the hospital. I can take it every 4 hours instead of every 6 hours. That's using it in a way that it wasn't prescribed. Now, that might be a minor difference, but in the hospital, you have more eyes on you as far as if you were to have some of these undesired effects. And it becomes a slippery slope where if a person is using it, most people who engage in non-medical use do so for pain. But if you start doing it to get sleep, you start doing it for the way that it makes you feel in terms of you get some boosted energy or euphoria or a buzz, then you're going down a slippery slope that may lead the person into substance use disorder. So we do use opioid-sparing treatments as part of the plan whenever opioids are used. And this is something that it's a best practice to have this plan mutually established in a patient-centered way that not just looks at pain reduction, but also functional improvement, so that we're using opioid-sparing treatments like acetaminophen or the NSAIDs I mentioned, like ibuprofen or naproxen. We use topical rubs. We use non-drug adjuvants like heat or ice or distraction, physical therapy, virtual reality, or the like. And we document and communicate the treatment plan, and we revisit the comfort function goals with each encounter to see what needs to be changed, because oftentimes the pain will evolve and change over time, and your responses to these different treatments will change over time. Just as I said with opioids, it may actually paradoxically increase pain over time. When you're using some of these non-drug adjuvant therapies, they tend to get more effective over time, and so that you may be able to reduce reliance on medications, including acetaminophen or the non-opioids, when you get better at using the non-drug ways of controlling pain. Topical NSAIDs, excuse me, are really coming into their own, that especially for pain that is what I'll call superficial. So it's close to the skin, either pain in the skin or pain just under the skin, or in shallow joints like the joints of the fingers or the knee or the toes, that putting a topical NSAID on that. And diclofenac, you might see the advertisements for diclofenac. There is a topical ibuprofen, like a topical Advil, that is available on the market. Meloxicam is another one. So there are some of these different topical NSAIDs that are available that provide higher concentrations right at the tissue level. Patients really like it because the rubbing action really helps, and you do feel oftentimes immediate relief when you put it on. It works for localized pain. And so the American Rheumatologic Society for the last 10 years has recommended this as being a first-line treatment for arthritis of the hand or of the knee. But it doesn't necessarily penetrate deep enough for arthritis of the shoulder or of the hip. And so there may be some limitations just as far as how deep these medications do penetrate. There's less gastrointestinal side effects than we see with the orals, and there's not the toxicity that I mentioned with the NSAIDs, such as problems with kidney function or gastrointestinal bleeds or heart disease that can be possible with day in, day out use. In 2019, the Department of Health and Human Services got together some of the best minds in pain control and had 9,000 public comments, many of them from persons and family members who are dealing with pain, about what are the best approaches to managing pain. So having a balanced approach that addresses not just the body, but also the mind and social interactions, what we call a biopsychosocial approach, an approach that's individualized and patient-centered, because different people respond differently to different therapies, finding out, well, what have you responded well to in the past? You've had pain before. Just about everybody who's seeking treatment for pain has had pain before. And so what have you done, both medication and things other than medications that have helped you to better deal with the pain? Opioid safety and risk mitigation, when that's being used, a multidisciplinary or multimodal approach, as we call it, when the pain is persistent or severe in nature, addressing stigma and access to care, education, and supporting research and innovations. And when we look at their ways of managing pain, that medications may be necessary, but alone they may not be sufficient. So we look at restorative therapies, interventional procedures, behavioral health approaches, and complementary and integrative therapies. And we look at these particular, when we look at these particular therapies, the different types of medications that have been shown to be effective for pain, acetaminophen, the NSAIDs that I mentioned, opioids, certain antidepressants like nortriptyline or duloxetine, anticonvulsants like gabapentin or pregabalin, muscle relaxants like tizanidine, biologic therapies for certain types of pain, and topical analgesics. There are restorative therapies like therapeutic exercises that you might get from physical or occupational therapy, transcutaneous electric nerve stimulation, or there are many electric nerve stimulating devices that have come to market in the last couple of years, massage therapy, hot and cold therapy, therapeutic ultrasound that you would also get through physical therapy, or bracing and compression. Interventional approaches such as injections, epidural steroids, either freezing nerves or burning nerves with these cryoneuroablation or radiofrequency ablation, or neuromodulation where you have surgically implanted electric stimulating devices that stimulate the nerves to alleviate pain. Behavioral approaches like cognitive behavioral therapy are very beneficial, as is acceptance and commitment therapy, mindfulness-based stress reduction, emotional awareness, self-regulation, things like biofeedback, relaxation, and hypnotherapy. Cognitive behavioral therapy is probably the best studied. You can get that individually or in group sessions, or now it's available over the internet or through virtual meetings and programs. Complementary and integrative approaches like acupuncture, chiropractic care, yoga, tai chi, nutritional supplements, spirituality, and wellness programs are all listed as part of these best practice advisories from the National Institutes of Health panel, as far as having enough research evidence behind it to say that these things really work for pain and we should be exploring it. So rather than dose increasing, for example, or looking only at medications as a solution to the pain problems, we should also look at using some of these other techniques as well. So having a balanced approach is really the name of the game. When we look at the best ways to control pain, we want to reduce pain intensity, we want to avoid or minimize potential harm, improve functioning, improve quality of life, and overall wellness. If the pain is mild or simple, we'll keep it simple. We treat the cause, we avoid flare-ups. Self-management approaches are first line, and using the over-the-counter medications are first line. But again, if you find yourself using even the safest over-the-counter medications for more than 2 weeks every day, that's something that you should be talking to a healthcare professional about and having it medically supervised. If pain is persistent or complex, we get help from knowledgeable professionals. We address multiple amplifiers and dampeners. We combine active and passive approaches. So passive approaches are things that people do to you for your pain. So they might prescribe medications or administer medications or give you a massage. And active approaches are doing things on your own behalf, such as doing stretching exercises, diaphragmatic breathing, mindfulness, and things like that that might help you with your pain. And then using some of the therapies that were mentioned earlier. And we can look at some of these types of things in terms of what are some of the targets that we want to do as far as at the tissue level, the spine, mind, spiritual, social interaction levels, because all of these things have been shown by research that if we do less of this stuff, so if we reduce inflammation, if we reduce the lack of oxygen, if we help people to have optimism and confidence in their ability to manage their pain, to do effective mental distraction, to have a strong faith and sense of purpose, and not be socially isolated or have overly over dependency, and to be able to effectively communicate. These are things that we can do less of the amplifiers and more of the dampeners to really help people to think, feel, and do as well as possible. So the name of the game is really around multimodal therapy. And so first and foremost, if we know what's causing the pain, we're going to have cause-directed therapies to prevent and treat the pain so that it will go away in an expedient and effective fashion. But then there's also symptom-focused matters, so that at the skin level, we might look at a steroid or non-steroidal anti-inflammatory drug to get at the inflammation that triggers and amplifies pain. We might use a local anesthetic on these peripheral nerves, the local anesthetic or acetaminophen. At the spinal level, we might use local anesthetic, opioids, muscle relaxants like the tizanidine, ketamine, calcium channel blockers, which is the gabapentin. And then we also do things that diminish the pain level at the brain level. But we can also look at the non-drug side in terms of what are some of the things in addition to the medications that we can do. So as much as we can hit these different targets, we're better off, because 1 + 1 = 3. If you combine two different techniques, especially if you combine some passive techniques with some active techniques, then you get a synergistic effect where you get a much better response to the medications if you're also doing something like relaxation or imagery or applying hot and cold. So team-based individualized care, I had mentioned that these are things that we really pay attention to in the multiple fashions, but we want it to be based on SMART goals. So having specific, measurable, achievable, relevant, and time-bound goals are things that are helpful. And when we talk about measurable, we talk about not so much the subjective measurable, which might be, I want my pain to go from an 8 to a 0, that's not really measurable in the same way as objective measurement. So if there's a camera that's following you around, or the satellites are watching your behaviors, how do those change as you get better, as your pain gets relieved and your functioning gets improved and you're less affected by some of the side effects or potential side effects of the medications? And so we do need to pay attention to the medications, but also taking an active role in pain control and finding out what is a level of pain that will likely need to be endured. No matter what pain treatments that we have out there right now, the best of them provide partial temporary relief. There's nothing that we've really found that provides complete permanent relief of pain, or that might be exceedingly rare. And so oftentimes as scientists, when we measure, do we have a successful treatment of pain, we might use a 50% reduction in pain for acute pain or cancer pain as being we have a responder or we have a success story. And for chronic pain, it might be 30% or a 10% improvement in pain, while we're also improving functioning and avoiding treatment-related harms. And so there was recently a systematic review of looking at hundreds of research articles on pain from acute pain that was not low back pain. And we see that on average, they were at moderate or levels, so 6.5 on a scale of 0 to 10. And we do see that the NSAIDs, whether they're oral or topical, do reduce pain by about 1 point. Acetaminophen also about 1 point. The menthol gels like icy cold or Bengay, a little bit less. Acupressure, a little bit more, although there was low quality evidence for that, and the electric stimulation. And acetaminophen and ibuprofen almost 2 points lower, but it didn't eliminate the pain. but it did bring it down. And there's also something called a placebo effect. So even people in these research studies who receive sham treatments like sugar pills, they got a positive response just from having confidence in the treatments, that the treatments would work. So whatever treatments you think will work, using them is going to help you get a boost from this placebo effect, whether it be medications or the non-medication approaches. So it's important when you have pain to have a trusting relationship with the provider that you have. A good match would be someone who listens to you and believes your concerns and experiences, and then you believe their concerns and experiences as well. Encouraging questions and concerns with the treatment plans, having mutual understanding about what that treatment plan really is, and being comfortable with making referrals and discussing some of the challenges with adherence. So for example, some people are reluctant in bringing up the fact that insurance doesn't cover it, or that you're not able to afford some of the recommended therapies, or it's hard for you to get away at a time that's available. And so having a provider that you're comfortable talking with those types of issues, and that is comfortable talking with you about those things, is something that we find very important. Giving and accepting social support, whether it be emotional, informational, belonging support, tangible support, and affirmational support, all of these things are really important when people are experiencing pain. And going with the flow, you might feel down but not out, and so pain can be controlled. Many people with pain do feel helpless, hopeless, and depressed. They have sleep problems, difficulty with simple tasks, but there are ways to take steps to improve these things, restoring joy and functioning in life and quality of life. But it really starts with baby steps, and this might be where we go back to having some SMART goals that are objective and measurable. I had a woman who hadn't been out of bed for 3 days because the pain was so bad. And I was just talking with her about, if we looked in a crystal ball for a year from now and she was completely better, what would she be doing? What does she really enjoy doing that gives her joy and meaning in her life? And she said, well, I'd go frogging with my grandchildren. And I asked what that was about, and it did involve walking with her grandchildren about a mile to catch some frogs and bring it back home so that the mother could scream and tell them to take it back outside, and they'd go outside and release the frogs. But it started with baby steps. It's like, okay, we can do that in a year, but it starts with you getting out of bed today and just standing, and then tomorrow taking one step, and then the next day taking a step towards the sink, and so forth. And you set goals so that you can make those types of improvements and ultimately achieve better functioning and goals. So I did want to thank you for your time and attention, and I saved a few minutes for any questions that there might be.
Thank you so much, Paul. We are now towards the end of the session, so if you have any questions for Paul, feel free to enter them in the chat box. So Paul, you had mentioned earlier on that some medications may include antidepressants, anticonvulsants for treatments of pain. How do those work?
Yeah, so that's a really good question. There's a symphony of different chemicals and nerve impulses that go into regulating our pain signals, especially when we're dealing with chronic pain. And so oftentimes, whereas we have used some of these antidepressants and anticonvulsants for short-term pain, like for surgical pain, we might use a dose or two before and after surgery, or for a day or two before and after surgery. That really the time when we use this is for the persistent pain, or the pain that's lingering for weeks after we expected it to go away. And that's because there is, the nervous system is so active that there are a lot of chemicals that either are built up that shouldn't be there, that are amplifying pain, or that there are usual chemicals that usually quiet the nervous system down that aren't there. And so that when we look at some of the medications that are used for depression, for example, what that does is that inhibits the reuptake of some of these calming chemicals. So it allows you to build up some of those chemicals that might be depleted in the spine and in the brain, that they're one piece of their normal activity is to quiet pain down. Now, we notice that in a matter of days or a couple of weeks, that there's a significant reduction in pain for people, especially when the pain is neuropathic in origin or nociception in origin, although it works for other types of chronic pain as well. And you don't get the antidepressant effects for 3 to 6 months later. So we know that it works by a different mechanism than purely that this pain is caused by the depression. In fact, we do know that the depression is caused by the pain in many of the instances, because we do see longitudinally an increase in depression the longer the pain does linger for people. Anticonvulsant medicines, by nature, their job is to slow down signals of pain. So they are that dampener switch. They turn the volume down on pain. They turn the dimmer switch down on pain, just because their action of slowing down the signals that are traveling in the nervous system. Not all anticonvulsant medicines do a good job of that, and not all anticonvulsants are as safe as the gabapentinoids, so gabapentin and pregabalin and some of the other newer drugs that are coming to market that are in that class. So we used to use Tegretol, for example, and some of the other anticonvulsants that are older anticonvulsants. And one of the things that we see with that is that liver damage can occur with those drugs. So we had to do blood tests every 3 months to make sure that there weren't any blood problems, there weren't any liver problems that were resulting from those medications. But comparatively speaking, the anticonvulsants that we use for pain are much safer than some of the more traditional anticonvulsants.
Thank you.
Okay.
For management of pain at Mass General, how does that typically work at Mass General? Does the patient work one-on-one with their doctor, their specialist? Do they get referred to a pain management program if that exists? Is it multidisciplinary, where they work with different specialists like yourself?
Yeah, that's a good question. One of the slides that I had said, if pain is simple, that we keep it simple. And so I'll call the attending physician or the admitting team as being the home team. And so that a lot of times the home team manages pain, that there are some very straightforward, typical approaches that the doctors and residents and nurses and physical therapists are familiar with. But when pain gets complex, and I set the bar at, and what our policy states is that when pain persists above the midline, above the midpoint of whatever pain scale that we're using. So if we use a 0 to 10 scale, and if we're not able to get the pain below a 5, that's a good time for us to really reevaluate. Do we need to call in the specialists for doing that? We're very blessed at Mass General. I'll often say if you can't find a specialist for whatever ails you within 5 miles of Mass General, that it probably doesn't exist on the planet, because we are a resource-rich environment. We do have a regional anesthesia perioperative pain service that helps with pain issues 7 days before to 7 days after pain. A lot of times they use epidurals or nerve blocks or other types of advanced pain techniques. There's an inpatient pain service, oftentimes for people with medical complexities. We have a pain champion program that we do have specialists like myself that have advanced knowledge that can also be called in to see patients. We have different palliative care services for people who have life-limiting diseases or are at end of life, and both adult and pediatric. We have a cancer pain program. And so we do have a number of different programs and specialists that are called in more on an as-needed basis. But I would say that 95% of the time that there are straightforward approaches that the home team knows that can be managed. One of the things about my role is that anybody can request my services, which is a little bit different than how the other pain specialists work in the hospital, where they need to prescribe or order for that. But but that's something that's been evolving over time as well.
Thank you so much, Paul.
Okay.
So we are just about out of time. Before we end today's session, do you have any final thoughts you'd like to share with the audience?
No, I would just thank people for participating and for their interest with this. And there's a lot of new and emerging information. You know, the NIH has put a lot of money behind better understanding and better treating pain. And so if we don't have a good treatment right now, I'm sure that we're going to keep getting new treatments coming down the pike every year from here on out. So thank you for this opportunity to address this important matter.
Thank you so much, Paul, for your insightful presentation. And thank you so much, everyone, for joining us today. Hopefully you found it helpful. As mentioned, if you'd like to view the recording of today's session, you may visit the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the afternoon.